Hi everyone, welcome to episode 34 of Tiny ADHD Superpower series. Today's episode is a little difficult, so pay attention. It's on ADHD and DSM5 introduction, and this is part 2. So the DSM5 Diagnostic and Statistical Manual of Mental Disorder, 5th edition, was first released in 1952. I introduced some of the history back in the last episode of the timeline. It's the official guidebook that psychiatrists, psychologists, and other mental health care practitioners use to define everyday mental health disorders. Clinicians use guidelines from the DSM5, known as the diagnostic criteria, to determine if a person has ADHD. You can think of these criteria as a checklist of symptoms. It groups the mental health disorders into categories based on sheer quality, such as mood disorder, eating disorder, etc., and lists the specific criteria for diagnosing each one. Since the DSM-5, ADHD is grouped into the category under Neurodevelopmental Disorders, as opposed to the older DSM-4, because it begins in childhood. So, before I introduce all the symptoms, I just want to say the criteria for DSM-5 for patients 17 and younger are greater or equal to 6 symptoms each category. And in those age 17 and older, greater and equal to 5 symptoms are necessary. So let's go over some of the symptoms for diagnostic criteria for ADHD. First, inattentive type diagnostic criteria. Displays poor listening skills, loses and misplaces items, sidetracked by external unimportant stimuli, forgets daily activities, diminished attention span, lack ability to complete schoolwork and other assignments of the following instruction, avoids or decline to begin homework or activities require concentration, and fails to focus on details and makes thoughtless mistakes in schoolwork or assignments. Second is the hyperactive impulsive type diagnostic criteria. The hyperactive symptoms are screaming when seated, marked restlessness that's difficult to control, appears to be driven by a motor, often on the go, lacks ability. I don't know how that is a disorder. DSM-5 definitely needs to change. Lacks ability to play, engage in leisure activities in a quiet manner. That happened to all the kids. Incapable of staying seated in class. That happened to me. That happened to everyone. Overly talkative. Difficult waiting for a turn. This is impulsive symptoms. Interrupts or intrudes into conversation activities of others, and impulsively blurts answers before questions are completed. This is extremely important, as I mentioned before, in adult ADHD in a professional setting. This is extremely important to practice, so you don't blurt out things. Instead, you write it down and you say it when the time is right. So, the classification of a combined type. Patient meets both inattentive hyperactive criteria for the past 6 months. Predominantly inattentive type is also for the 6 months. And for both hyperactive impulsive type, it's also for the past 6 months. And again, like I said, they had age less than 17 is 6 symptoms. Age greater than 17 is 5 symptoms. So I'm just going to do a little comparison of DSM-4 and DSM-5, because DSM-5 goes into more detail on exactly how the behavior is when you talk about certain symptoms, but DSM-4 doesn't really introduce that. So it makes it a little bit more clear for psychiatrists, psychologists, when you actually administer DSM-5 to narrow down to the specific symptoms that is necessary to have a proper diagnosis. So let's get into it. There is 6 A to E criteria. Sorry, that's 5. I'm stupid. Criteria A are unchanged for DSM-4, except for additional examples of how symptoms may manifest in adolescence and adulthood. So DSM-5 focuses a lot more on the adulthood than just on the childhood, which is like before. And reduction from 6 to 5 in the minimum number of symptoms in either symptom domain required for older adolescents and adults. Criterion B, age of onset, change from onset of symptom and impairment before age 7 to the onset of symptom before age 12. This is extremely important, especially when diagnosing children ADHD. criteria, because I mean, the brain developing, like every single year, and personally, I don't think that diagnosing kids with ADHD, I think it labels them as disorder instead of something that could be a superpower like what I have. Well, I'm not saying that I have it, but anyways, I do. So yeah. Anyways, moving on to criterion C, pervasiveness. It will change from evidence of impairment to evidence of symptoms in two or more settings. Criterion D, impairment, now requires a functional impairment only needs to reduce the quality of social, academic, or occupational functioning instead of requiring that they be clinically significant. Criterion E, exclusionary condition, no longer includes autism spectrum disorder as an exclusionary diagnosis. Regarding nosology, the DSM-4 ADHD types are now referred to as presentations, which is good. It's a good word. Finally, modifiers were added so that the severity of disorders such as mild, moderate, or severe can be specified, and disorder can be coded as in partial remission if four diagnostic criteria are not currently met. So, I guess I'm going to leave PTSD until the next episode because this is going on 6 minutes now. So, when I was on severity just now, there's 3 severities: mild, moderate, and severe. I'm not going to go into it. I mean, that's self-explanatory. And I will go into PTSD and DSM5 in the next episode and how it affects ADHD. Thank you for watching. Bye.